Hey, it's Beth Wright, and I'm providing you a podcast for Unit 6, NUR 236, and we're talking about medications that are used for dyslipidemia, okay? Now, we got to talk about blood lipids. Lipids, when we hear the word lipids, we got to think fats. And of course, a lot of that is derived from the diet, of course. And it is synthesized by the liver and intestines. And we end up with cholesterol, phospholipids, and triglycerides. And of course, these are found in the body. And we got to have fats. I mean, we can't completely cut fats out in our diet or lipids, but too much of a good thing is not a good thing, right? So it is transported in plasma by the lipoproteins, and again, each of those lipo or lipoproteins, however you want to say it, contains the cholesterol, the phospholipids, and the triglyceride, and it's bound to protein. And the density is determined mainly by the amount of protein in there, so the density is increased as the protein is increased. And we want to pay particular attention to our high density lipo or lipoproteins and our low density lipoproteins. Okay, so just thinking about when we look at these lab values for this, we want to keep the high density lipoproteins or lipoproteins high. We want to keep them high. And we want to keep the LDL, the low density lipoproteins, low. So that's our goal in treatment. So we got to keep that in our mind. So dyslipidemia or hyperlipidemia, you may see that terminology as well, is when we have an abnormal lipid level in the blood, and of course it's associated with heart disease, with myocardial infarction, atherosclerosis, and strokes. Because when we have too much of the fat in the blood, it's going to make the blood thicker. It's going to impede that blood flow. And so, it can also lead to that plaque buildup and that kind of thing that leads to an impaired blood flow, again, to the heart or to the brain. So that's why we want to keep this under control. So our cholesterol level that we want to see, and that's your total cholesterol level, is 150 to 250. And for the LDL, the low density lipoprotein, that's the bad cholesterol, we want to see it below 100. And for our HDL, that's the good cholesterol, we want to see it high. And the normal levels are 40 to 60. So we want them to be normal or even higher than that if possible. And triglycerides, we like to see it below 150. So again, we got to think about folks with our cholesterol. We got to think about the ones who are at risk for coronary artery disease, and stroke and that kind of thing. So we can do a tremendous amount of teaching with individuals, and you may see goals set differently for individuals with already diagnosed with coronary artery disease or atherosclerosis. You may see some goals set higher than what our normal levels should be, because they're already at risk. And you hear about the metabolic syndrome. Those folks, they can have definitely some issues with cholesterol and triglycerides and the fats and things. So that they may have different goals set. And with the metabolic syndrome, you have a group of different characteristics or risk factors that are linked to this syndrome and linked with obesity. And so these folks have an increase in that waist circumference, waist circumference, an increase in their triglycerides, an HDL is low, the blood pressure's up, and their blood glucose is elevated as well. And of course, metabolic syndrome can lead to coronary artery disease. So, if we have individuals with these kinds of things, we want to try to work with all of those types of signs and symptoms there or risk factors that to try to get them reversed. Now, our drugs for dyslipidemia, again, the major thing is using them with folks who are having the risk factors and atherosclerosis or any kind of vascular disorders, such as the coronary artery disease, stroke, the CVA, cerebral vascular accident, or peripheral arterial insufficiency. And it has been proven to reduce mortality and morbidity. So hyperlipidemia is associated again with atherosclerosis and many pathological effects within the vessels, but we know that it can lead to an MI and ischemic damage to the heart, as well as a stroke and peripheral arterial occlusive disease. Because if you got something in there taking up the space of the vessel, then it's going to impede that blood flow to the heart, to the brain, and other important parts of the body. So it can be primary dyslipidemia. It can be a genetic, familial type thing, or it can be secondary from dietary habits and different disease processes that aggravate it, such as diabetes, alcoholism, hypothyroidism, obesity, or liver disease. So our NCEP, that's our National Cholesterol Education Program, and they're in their third study according to the book. And so we're going to be monitoring with this the cholesterol, total cholesterol, and the LDL and HDL, and the triglycerides to make the biggest impact on that. So we're going to assess for and treat conditions known to increase, so such, things like as lifestyle issues. We're going to stop medications that increase the blood lipids, and some of those can be cardiac meds, they can be antipsychotic meds, anti-seizure meds, hormones, and some immunosuppressants can cause an increase in the blood lipids. So if possible, we need to try to get off of those medicines if possible. Sometimes we can't do that though. We want to encourage to start a low-fat diet, and so things like egg yolks and fatty meats, organ meats, whole milk and butter would need to be avoided, and they should eat things like salmon and sardines. Yuck. I don't know how anybody could eat those, but anyway, olives, flaxseed oil, shellfish, walnuts, fruits, vegetables, lean meats, and skinless fowl are foods that would be considered low fat. And then it talks about the Mediterranean diet, which is low fat. Soluble fibers, because that helps bind with the cholesterol and get it out of the system. So that's going to be things like oatmeal, nuts, beans, apples, and berries, certain berries there. And dietary supplements and cholesterol lowering margins. Also, weight reduction diet if the patient is overweight or obese, and regular exercise, aerobic exercise, and to stop smoking, and postmenopause hormone replacement therapy has been recognized to help lower this. So our characteristics of the medicine, we want to decrease the lipids and delay or prevent atherosclerotic plaque development and promote regression of existing atherosclerotic plaque and reduce the mortality or morbidity of the cardiovascular disease. So the medicines either alter production, absorption of lipids and lipoproteins, or the metabolism and removal of lipids and lipoproteins. And so pharmacotherapy is initiated when 6 months of dietary changes cannot do the job. And this is also going to be based on how high the numbers are, also how high the lab values are. If somebody's got a triglyceride level of 1,000 or more, I've seen that many times. They may get them started on medicine immediately to get that down, or if the cholesterol is really elevated. So these are your exemplars, your HMG-CoA reductase inhibitors, and those are the statins. They have statins at the end of the generic names. We also have the bile salt sequestrants, and we have the fibrates, and then we have cholesterol absorption inhibitor, and then we have niacin, which is a vitamin B. So let's talk about the HMG-CoA reductase inhibitors. Atorvastatin is one of your common ones there, and again, they decrease the total serum cholesterol, and that's how they're used. They lower the cholesterol. Well, of course, by lowering the cholesterol level, the patient is at a decreased risk for MI and stroke. Now, this works on the total cholesterol, and it lowers the LDL and triglycerides and the VLDL, which is your very low density lipoproteins. And it works by inhibiting the HMG-CoA reductase enzyme that's needed for the hepatic synthesis of cholesterol. So obviously we're going to be working in the liver here for this. This medicine must go through a first pass metabolism by the liver, so you know what that means. It goes to the liver, then it's metabolized, and then it starts its work. The adverse effects are nausea, constipation, diarrhea, abdominal cramps, skin rash, myopathy, meaning that you hear people complain that started this medicine, their muscles and their feet and really, really hurt. So it can injure muscle tissue, and we got to be real careful about that, because if that happens, then we need to get on a different medication. Also, hepatic dysfunction is an issue here. So we got to monitor those liver function tests, as well as the muscle injuries for folks taking this medicine. Women of childbearing age should use birth control, and because the bulk of the cholesterol synthesis occurs at night, it's good to take it at night or at bedtime. Now, our bile salt sequestrants, cholestyramine is the medicine. This medicine binds bile acids in the intestines, excreting them in the stool, and it reduces the LDL and may actually help increase the HDL, which is something we want to see. The H is high, and we want it to be high. Now, these are tablets. But also can be a powder form. So we got to be sure to teach them. You got to mix. If it's a powder form, we need to mix it with something. We don't just put that powder on our tongue. So we got to mix it with something. and then drink it. And of course, any any type of medicine, the way this works is it binds with things. So if we're taking other medicines, it can also bind with them or decrease the absorption. So we got to be careful about that. Adverse effects is GI discomfort, anorexia, and steatorrhea, which is a fat stool that has fat in it. It is contraindicated with anybody that has a complete biliary obstruction. We need to do the teaching as far as mixing this medicine with, if it's powder form, mixing the medicine, also the absorption of other medicines being affected, so they need to take other medicines 1 to 2 hours before they take this or 4 hours after. And also dental hygiene is important because it can damage the teeth. Our fibrates are derived from fibric acid, and it is similar to the fatty acids. And fenofibrate is your prototype for this. Oxidizes fatty acids, which decreases hepatic production of triglycerides, and it helps decrease the very low density level cholesterol and increases the HDL. So it's indicated in patients with triglycerides with greater than 500, contraindicated with severe renal impairment. Got to be careful with diabetics, and it can be hepatotoxic, so we got to monitor the liver panel. Adverse effects, again, are GI discomfort, diarrhea, could cause a formation of gallstones, the myopathy, the rhabdomyolysis, which is part of the muscles being damaged, blood dyscrasis, meaning that it can cause blood cells to be abnormal, and pancreatitis. Drug interactions, warfarin, got to watch about bleeding for that. And of course, therapeutic effects, we want to monitor the lipid panel to make sure that this is working. The cholesterol absorption inhibitor, ezetimibe, is your medication for that, and it reduces the total cholesterol and triglycerides and increases HDL. It acts in the small intestines to stop that absorption of cholesterol. And so it can be used solo by itself, or sometimes you may see this used with a statin medication, the HMG-CoA reductase inhibitor. Adverse effects of this is headache, diarrhea, and nausea, possible rash. It is contraindicated with pregnancy and liver impaired if taking a statin and this medication together. And then our niacin is our last one. It's a vitamin B3 that decreases the LDL and the increase as HDL. Now, the thing about this, it has to be administered in high doses to be effective, and that can cause stomach irritation because of that. But it is on the cheaper side of the treatment for this. The high levels of vitamin B3 can decrease the triglyceride levels and raise the HDL level. Again, it can cause the GI irritation, pruritus. It has a vasodilation and flushing side effect as well, but we can tell the patient or talk to the doctor, of course, make sure it's okay. But if they take a baby aspirin or an adult dose about a half an hour before they take the niacin, then that will help the flushing. And they can also have pruritus effects, and that can help with that as well. If they it causes vasodilation. So if they are taking an antihypertensive, along with this, they might get too much of a hypotension effect of that. So they need to be careful about that and watch about that. Even though it's better to administer without food because of the stomach irritation, it is recommended that it can be taken with meals. All right, that concludes your podcast.